Welcome, everyone. We will be getting started shortly. We'll just let some folks time to log in. Thank you, everyone, for joining. We'll just waiting for a few more folks to log in, and we'll get started in just a minute. Okay, as folks will be joining, we're just going to go ahead and get started. Thank you so much, everyone, for joining us. This is the first of a three-part series hosted by the Subcommittee on Accessibility, Fellowship, and Engagement. For those of you that aren't familiar with our new name, this is what we now refer to as the SAFE Subcommittee, but we were formerly known as the DEIA Subcommittee. And really, the goal of our subcommittee is to foster a professional community where all members have equal opportunities to contribute, grow, and thrive while advancing consultation-liaison psychiatry through care, education, and scholarship that address the needs of economically, educationally, and medically disadvantaged populations. And with that in mind is really why we've created this three-part webinar to kind of cover some of these important topics. So this is our very first, and it is my pleasure that today we will be having Dr. Anique Forrester, who is an associate professor of psychiatry and the Consultation-Liaison director and fellowship director at the University of Maryland School of Medicine. And she's going to be presenting on treatment disparities in perinatal psychiatry, inequities across treatment environments. Before I hand it over to Dr. Forrester, I do want to mention a couple things. One, we will have a brief post-webinar survey that will be distributed through the chat, and also it will be emailed to you. And please take the time to complete the survey. It's really short, 2 questions, but it will help us gather feedback about the webinar and really inform future programming and webinar content. We also have, as I mentioned, 2 more webinars scheduled. One will be increasing accessibility in academic presentations. That will be on August 19th. And then another one on the importance of practicing consultation liaison psychiatry with cultural humility, which will be on September 23rd. These will all be at 12:30, and in the emails, you'll be able to register for those as well. And with that, I will hand it over to Dr. Forrester. There will be a 5-minute question and answer at the end. So please, if you have any questions that come up, put them in the chat and we will give time for that. So without further ado, Dr. Forrester.
All right, thank you so much. Let me go ahead and share my screen so that everybody can see the presentation. Just making sure we can get to the show. Okay, here we go. So we will be talking about perinatal psychiatry and treatment disparities today. I have no relevant disclosures. So today we're going to discuss stigma and treatment hesitation within psychiatry regarding the care of pregnant patients who have serious mental illness. We're going to review the importance of education to alleviate care disparities across different treatment environments, which is where CL psychiatry tends to show up. And then also highlight the need for coordination of care between regular psychiatrists, CL psychiatrists, and along with OBGYN, and issues related to obtaining informed consent during extended treatment episodes. So here is the case. This is a real CL case that we've seen here at the University of Maryland. She's a 22-year-old woman who was brought to the emergency room via what we call an emergency petition. And this is what forces psychiatric evaluation for community members where there's concern about safety or dangerousness. This patient had assaulted her 10-year-old nephew and reportedly had attempted to set the family home on fire. She was diagnosed with this sort of combination bipolar schizophrenia, which is fairly common terminology we see here in the Baltimore area since age 19. She's 30 weeks pregnant, which is confirmed by ultrasound in the emergency room. The fetus is not in distress. The patient, though, denies that she is pregnant, and she attributes her symptoms to lots of general medical conditions, including diabetes, what she describes as thyroid stuff and migraines, even though none of these things are in her records. She denies suicidal and homicidal ideations, but she is somatically preoccupied, and otherwise she's medically stable. Per the patient's mother, her first psychiatric hospitalization occurred at age 19. She was muttering incoherently to herself, fairly paranoid. She stopped caring for her hygiene. She has this chronic paranoid belief that the family house, is being poisoned by gas, and she had actually started sleeping on the streets because of that belief. And so what had happened from age 19 to 22 was a recurring cycle where the patient would be briefly stabilized on antipsychotics in the hospital, but she would stop medications after discharge and have a rapid psychiatric decompensation. So this is the story of her coming in at this time. The patient also repeatedly refuses depot antipsychotic medications after discharge, so long-acting injectables. Her family is unable to sustain her engagement in mental health treatment. And so when we think about a health equity lens, this is what I would like for you all to think about, is sort of the impacts of her housing instability and unsupported treatment cycle, and how these are social determinants of health, which are shaping this patient's presentation long before she arrives for this emergency room visit. So the patient is actually admitted involuntarily to our inpatient psychiatry unit, and she remains on that unit for about 6 weeks. During the course of that 6 weeks, she's treated with oral Haldol. She requires nearly daily IM PRN medications, which sort of raises a red flag as being fairly unusual, especially with such an extended treatment episode. She was also transitioned to oral risperidone for improved tolerability, was what we see in the chart. But a depot or long-acting injectable antipsychotic is not started, and the rationale, both written in the chart and when you have conversation with the inpatient treatment team, is because she is pregnant. And so when we think about this raises a question about implicit bias. So pregnancy alone is not a contraindication for long-acting antipsychotic injectable medications. And so there's this concern now that this reflects this categorical assumption rather than being reflective of a true individualized risk-benefit discussion with the patient, and also understanding that pregnancy alone is not a contraindication for long-acting antipsychotic medications. And so there is another decision point that happens in the course of this 6 weeks. The OB/GYN team and the inpatient psychiatry team decide to induce the patient's labor at 36 weeks. It's actually unclear from the records how involved the patient and the family were in these discussions. And the stated reason, which is unfortunate, is to get her out of the hospital. This is what's actually written in the record, which is, we know, is not an obstetric indication to induce labor, especially preterm, right? The patient delivers a healthy infant vaginally. And so when we think about health equity in motion, so we are trying to resolve a system capacity problem. So whether it's because of this extended stay through a medical intervention, right, that's imposed on the patient's body, not a clinical need, because she was not otherwise in distress. The fetus wasn't in distress. There was no other indication to induce the labor. And those things now are starting to drive the care versus the medical needs of the patient. And so as a CL psychiatry team, we get involved now. The patient is on labor and delivery and has delivered this infant. What the OB team tells us is that they will monitor her for 24 hours on the labor and delivery unit because the delivery was uncomplicated. They tell us that she has also agreed to implantable contraception, which will be placed on the day of discharge. And the OB team is asking the consult team, should she return to the inpatient psychiatry unit? That's sort of the extent of their worries. On the psychiatric evaluation, the patient is calm and cooperative. She describes to the team that she has had a baby this morning, but is unclear where the baby came from. And she actually continues to deny that she was ever pregnant. She denies, again, suicidal and homicidal ideations, but she does have these paranoid ideas about her family. But again, she denies any plan to harm anybody in the family. When we talk about her experience on the inpatient psychiatry unit, the patient says it's a prison up there. She doesn't want to return. She also agrees that she'll see a psychiatrist. She'll take whatever medication they tell her to take, but she doesn't know what she's been taking for the prior 6 weeks. So again, we're getting back into issues around informed consent. What sort of things have been happening with these medications on the unit and the almost daily requirement for IM medications. And when you kind of try to dig in further with the patient around the need to take medications, maybe even exploring long-acting medications, she says, I can't worry about that now. I have to take care of my baby. So we can see that there's some sort of lack of cohesion around her ideas that she has a baby, but also that she was never pregnant. So the delusions are still fairly present. As a CL doc, we do also then have to coordinate with our inpatient psychiatry colleagues. When we talk with them about the patient, they describe her as a difficult patient, which can have a lot of connotations from a health equity perspective. When patients are described as difficult, they sort of consistently confirm that the patient has been delusional and paranoid throughout this 6-week admission. She has never attempted to harm herself or anyone else on the unit, which also sort of doesn't make sense with the fact that she was getting almost daily PRN medications. She remained convinced from their perspective that she was never pregnant. And the team does not believe actually that she requires a readmission to the inpatient psychiatry unit. And they're asking now for the consultant's help to convince the patient to accept a depot medication. Especially after a long extended treatment episode, this feels fairly unusual. So what happened to this patient was that she actually did now agree to an IM depot of Invega Sustenna. Invega, as many of you might know, requires an initial dose and then a second loading dose is due in 7 days. And she agreed to the outpatient psychiatric follow-up within 7 days to get that second dose. Social services actually declined to open a case around the infant. And the stated reason from them was that she hasn't actually harmed the newborn. And she was actually being allowed to have unsupervised time with the newborn on the labor and delivery unit. The consult team asked for a family meeting to help determine sort of safe disposition and to coordinate further around her treatment needs. And in that meeting, it was determined that the infant would be discharged to the care of the patient's mother, with whom the patient actually lives. And when we think about healthcare disparities, one of the things that we identified in this case is that the safety net responds to harm that has already occurred, but not really to accumulating risk. When we think about accumulating risk for this patient, untreated serious mental illness, homelessness, a lot of these things were identified before her initial presentation to our emergency room, and we're wondering around the disparities in how this patient was cared for and why it was so difficult to engage her in mental health treatment. And so at this point now, after this delivery and this extended treatment episode, the follow-through is almost left entirely to a family who doesn't have a lot of supports, as it's evidenced by the fact that they could not sort of successfully get her to engage in mental health treatment or to accept medications during the time that she was not pregnant. The family in this meeting also agreed that the patient could not be left alone with the infant and that they would call 911 if there were concerns about safety or if the patient further decompensated. So this felt fairly sort of unsatisfying when we're looking at a very long treatment episode with a patient with serious mental illness. And so to kind of let you all know what happened, the day after discharge, the patient, Miss H, and her mother took the infant to a pediatrician appointment that was scheduled. She became angry for unclear reason and actually attempted to take the infant out of the office. The mother stopped her. The infant was not harmed. She left the office on her own, but the family could not reach her. So we're going back to some of the disparity issues that we've identified and how the family was fairly unsupported in this disposition plan, and the patient was subsequently lost to follow-up again. So when we think about health equity, And then we highlight this case because there were so many areas here within which, from a health equity perspective, and the definition here is the opportunity for everyone to reach their full health potential. And that opportunity should be unhindered by their social position or their circumstance. And so, how could we have done a little bit better to help this patient achieve equity in how her healthcare was administered? What are some of the limitations that people are recognizing from some of the things that we've talked about that led up to her admission to the hospital? And also, where could we have intervened during this, again, extended treatment stay? And then we think about health inequities, right? These are systemic, avoidable, and unjust differences in health status rooted in the conditions in which people live. So, what is it about this patient that makes her prone to healthcare inequities? We have not talked about her socioeconomic status. We have not talked about her race or ethnicity. We haven't talked about any of those other things that are typically applied to those, because in our discussions that we have in our learning conferences around health equity, we try to have the team imagine what those things could be so that we can talk about how they apply when we actually see patients in real time and how they might apply to social determinants of health. Again, the conditions, the housing, income, and support that shape individual patients' access to care. For this patient, the housing instability, the family strain were some of the biggest social determinants of her health and why she ended up in this particular treatment episode. And then intersectionality, how the patient's overlapping identities and circumstances can also affect the care. So we find that if we supply all of that information, people don't think about it sort of without bias and without their own assumptions. And so when you think about for this patient, this is somebody with serious mental illness who is pregnant. There's a lot of stigma still attached to pregnancy and mental illness, who has limited supports, but there are supports that are there. And the family is also limited in how they can support her. And all of these things together compound this patient's level of disadvantage when it comes to some of the things that happened to her. How did we get to informed consent? How did we decide about medications? How did we decide to induce her? And when we think about disparities in perinatal treatment, women of color, women of lower socioeconomic statuses tend to be exposed to higher risk interventions or to have interventions that then preclude them to have poor health outcomes down the line. And these are things that we've heard about, that we know about, but this case kind of highlights how those things compound and how they pile onto each other to disadvantage individual patients. So with that, we have some questions for discussion that I will send over to Ariadna, Dr. Foray, to kind of lead us with, and then also see if there are questions in the chat.
Great. Thank you so much for that very thought-provoking presentation and case. So we can start off with, I don't see any questions in the chat yet, but maybe we can start with thinking about one of the questions that you have here. Where in this case did a clinical decision, in this case, maybe not offering a depot medication or consulting with a perinatal expert, substitute for an individualized risk-benefit conversation? Anyone can add something in the chat if you want to respond to that. Give it a minute for folks to think about it and before asking Dr. Forrester to comment on it. And maybe while folks think about this, Dr. Forrester, do you want to kind of give us your perspective?
Yeah, and I think this is where we think about how does implicit bias show up? How do we make clinical decisions on a day-to-day basis? And implicit bias really has to do with our unconscious thoughts, feelings, and beliefs. And sometimes when we are uncomfortable with a situation, and pregnancy tends to bring this up a lot of times. I think it's getting better, but it's not as consistent as it should be, where those sorts of things now start to take center stage in how clinical decisions are made versus sort of taking a step back, utilizing expertise that may be within our institutions, or maybe even reaching out in larger organizations such as ACLP to figure out how would somebody work with this? What is the typical standard of care? And how are we acting within that or outside of that? And again, when patients have serious mental illness and they're on inpatient psychiatry units, do we have the same level of responsibility to talk about risk benefit conversations when we're talking to them about medications, the same way we would as consultants on a medical or surgical floor? So those are some of the things that come up when thinking about this particular question.
Yeah, and I think one of the things that I really like to think about when considering particularly perinatal patients or pregnant patients is really it's a risk discussion, right? Untreated maternal mental health symptoms are a risk to the individual, to the pregnancy. So this whole idea that it's a simply risk benefit isn't really true. It's really a risk. There's risk of not treating, that you have to weigh against the potential risk of medications. And in general, a lot of the medications that we use tend to be not have and carry major teratogenic effects or adverse effects to the to the pregnancy or the developing fetus. So it really is so critical, right? And I think that there's a lot of opportunity there for teaching. And I really appreciate your point to sort of like there are resources, right? Some states have the perinatal access programs that they can call, but if not, there's also sort of turning to, ACLP and you know, a reaching out to colleagues. So there's a lot of expertise within our academy around this. So really kind of wanted to point that out. One of the things before I know we have a few more questions, but that really stood out for me in this presentation, and I know that this happens, I think a lot of times for us in CL psychiatry, right, is that there are all of these health inequities that occur to the patient, right? As when not when we're interacting with them, but like they're experiencing this, and it leads to the presentation, right, through their hospitalization, and then we're suddenly as consultants kind of left to be like, oh, by the way, there are all of these intersecting issues at play here that are contributing to this presentation, which is really complicated, and there aren't many resources, and suddenly now you have to solve this. So I was just wondering if you can kind of comment a little bit more on that and kind of what that was like for the team when you were having to deal with this in particular case.
Absolutely. And this case actually helped us to spark having sort of regular health equity discussions because of all the intersectionality that occurred here and all the compounding inequities. And I think one of the big things that we've learned to do, because yes, there is this pressure immediately as a consultant to solve the problems, but many of these things are systemic or structural issues. And so we have now sort of developed a process where we think about opportunities for advocacy. So one of the things we think about with advocacy is sort of making it clearer what supports we had internally for this. And so we've sort of, since this case has happened, developed a lot more robust sort of support and teaching around perinatal issues. We have a whole women's health program here. And so making sure that people are aware of those resources and then thinking about things on larger levels as well, like what sort of things do we need to change systemically around how serious mental illness is treated and how we sort of deal with patients that may be chronically unhoused or have limited supports, because those patients may also end up pregnant. And so, what do we need to think about differently with that? So, there's a lot of things that it sparks in the conversation, but we try to remove the responsibility to fix systemic and structural issues on the individual cases.
Yeah, yeah. And I do see that we have a question. Was there a discussion with the inpatient team regarding the documentation about LAI not being offered? If yes, how was it handled and received?
Right. So, yes, there was. And one of the big things I wanted to point out here is that during this time, which is another sort of like inequity sort of system resource allocation question, during this time that the patient was there, there were multiple rotating attendings on the inpatient psychiatry unit versus one attending or a smaller set of attendings who would have taken more responsibility for kind of advocating for more resources or reaching out to find out who was who. And so this brings up a larger question around staffing and how things should be staffed. But we did have the conversation with them about it. We did talk about how there was really no contraindication to this and that there was risk in terms of delivering almost daily IM, PRN medications with staff safety, patient safety, the need to apply physical holds. So those things need to be considered as well. Not just the risk sort of conversation as you brought up with the medication in and of itself. It's the untreated mental illness and all the situations around it.
Wonderful, thank you. And there was, sorry, just another comment that we just realized. Thank you that the chat function is disabled. So if you do want to ask something, just do it through the Q&A. Um, so while we wait for other questions, I think maybe one of the ones I was curious out of our discussion questions here is, and we've touched about on this a little bit, but maybe what would a proactive rather than reactive acute care triggered safety net have offered this family?
Right. So when we think about patients with serious mental illness, we don't want to wait for them to have like this acute issue, like the pregnancy or something like that, this one thing about them to differentiate them from other patients with chronic serious mental illness. And so the conversation really is about what does something like an ACT team, an assertive community treatment team look like? Where you live, and how is it able to respond readily to the needs of patients, including when they become pregnant? Right? Do they have the same access to supports and resources to be able to treat patients like this when they are pregnant so that the treatment sort of episodes don't get then interrupted with the acute care hospital setting? How can they support people going to prenatal visits and making sure that they're consistent with their both mental health and somatic health concerns throughout the course? So this really is talking about things like assertive community treatment and making sure that we are offering sort of those levels of services to patients and their families. This patient seems like she had her first break at 19. Do we have first break clinics in Maryland? We're lucky to have the RAISE program, which is a very structured and supported clinical and research initiative around first break of schizophrenia. So we're lucky to have that, but we understand in other places they may not. What do we have in terms of assertive community treatment? Do we have supports to get people the care that they need where they are versus relying on them to come to us in hospitals, right? Or in acute care settings?
Great. And I know we're almost up on time. Just as a reminder for folks, as we're wrapping up, that there is a link in the chat for you to complete a brief, very brief survey on this webinar and any future topics you might be interested in hearing about. And one of the things that frequently comes up, and curious to hear your thoughts, and I know it is not a straightforward question to answer, is we frequently get these consults from the OB floor when a patient with serious mental illness delivers about their capacity to parent. And I'm wondering whether this had come up in this case, and your thoughts about that, and also how sort of there's some of these intersecting identities and factors might impact when that all comes and when parenting ability comes into question.
Absolutely. So it's interesting that did not come up in this particular case. It was actually raised by the consult team to say, hey, what are we doing with this? Now, there is a sort of more automatic process to get like social services involved when they're sort of concerned that this patient had come from an inpatient psychiatry unit. But in the interim, before like social services had made specific determinations, like no one had said, should she be allowed to be alone with the infant? She was already having unsupervised visits with the infant. So it does require a little bit more thoughtfulness on how do we do this in a way that doesn't stigmatize patients, because having a psychiatric diagnosis or serious mental illness does not automatically make you unsafe to parent. But we need to have these conversations. And I think this case also highlights that we had time to do so. This is not a patient who came in just for delivery. It was like a very, emergent situation. We had to do an emergency section or something. This is somebody that the OB team was consulting on when she was on the psychiatry unit. So this need to have this sort of cross coordination of care is critical. And even more critical for patients who are vulnerable and sort of impacted by multiple sort of healthcare disadvantages and inequities.
Wonderful. Well, thank you so much for that. I think really we are now at time. time, but this was such a wonderful presentation and discussion. And I want to thank you for being our first presenter in this three-part webinar series, and everyone that joined us. And we look forward to seeing all of you again in August and then again in September. Thank you so much.
Thank you. Bye-bye, everybody.